we are very pleasant to present you the commercial symposium. It's supported by BMODE Medical, Quantel Medical. And it's a pleasure to us to talk and to be the diamond sponsor of this Congress, the SIDUO Congress. And we have the opportunity to share something that is in our portfolio, but we are not trying to say about products, we are talking about techniques. We are open to discuss. I think the best device that exists is the one that you have, but we have alternatives. It's just our feeling to share some experience for some users of our device. In the very beginning, I will present Gabriela QUEZADA. She is, I'm very proud to tell that she's my fellow. She's a very, very, very good fellow during this time. Right now, she works in Lima in my diagnostic center. He is the responsible of my diagnostic center. You might imagine if you let something to someone, should be the best person to delegate that kind of task. And Gabriela will talk us about UVM in glaucoma. For us, one of the main indications for the use of the 50 megahertz probe in glaucoma is essential. Right now, we consider, I'm a glaucoma specialist, we consider that there is no serious glaucoma department if they don't have an UVM. Doesn't matter which one, an UVM machine, because you must see beyond the iris what's going on, especially in the risk of angle closure. Gabriela, please. One question before. We have also, for Quantel, 4 books. We make a raffle the last day with the people who stay here in the marathon, and 2 of them will be for the presenters, the residents and the doctor that did the presentation. And the other 2 for the rest of the participants. In this case, we can to encourage everyone to present papers in the next SIDUO, and we are waiting for you because the next SIDUO will be a surprise also for all of you. Good. Okay, Gabriela.
Thank you. I want to express my gratitude to SIDUO organization, Dr. Ramiro Prada and Dr. Andrea Vasquez, and BMODE Medical for the opportunity to share about UVM in glaucoma today. I will present my own cases glaucoma, where the UVM was a great diagnosis tool. These are the different tools that are used in glaucoma diagnosis, and the UVM is the greatest complement for see and measure all the structures in anterior pole. The great advantage is that you see behind the pigment, and is a great help to determine the origin of glaucoma. History. UVM is a high-resolution ultrasound technique that allows non-invasive in vivo imaging of structural details of the anterior ocular segment at near light microscopic resolution and provides detailed assessment of anterior segment structure. It was developed by Pavlin, Gerard Foster in Toronto in the 90s. This is the evolution of different UVM machines. And to the right, you see the absolute, the state-of-the-art machine in UVM. Characteristics of UVM. It uses ultrasound frequencies between 25 to 75, but the most used one in our practice is 50 megahertz. It's allow excellent resolution, a larger visualization of the anterior pole structures, a better evaluation of the structures behind the pigment. It is the gold standard in ocular media opacity. It helps and discriminate the cause of the angle closure. It's no invasive method and a dynamic study in real time. It's a good cost-benefit relationship. In this picture, you can see the comparison between OCT and UVM. And you can see the UVM is the gold standard because it allows you to see behind the pigment. When you have a lesion in anterior pole, the UVM is great, is perfect for see this lesion and measure these lesions. With UVM, you can evaluate all the structure in anterior pole: cornea, conjunctiva, sclera, anterior chamber, anterior and posterior capsular lens. And in addition, UVM allows for the identification of foreign bodies and evaluation in ocular trauma. You can use a scleral silicone coat designed by Dr. Mario de la Torre, or clear scan. And you will perform an axial panoramic scan, a longitudinal scan, a transverse scan, and you can see all the structures. UVM in glaucoma is an important tool in diagnosis, evaluation, and follow-up of glaucoma. The mechanisms of angle closure can be revealed by performing an UVM. The device can help differentiate between the two types of glaucoma, even in patients with opaque corneas, when gonioscopy cannot be performed. But remember, in clinic, the gonioscopy is the gold standard. Knowing the type of glaucoma is vital, especially regarding an adequate treatment in order to prevent glaucomatous optic neuropathy and visual field loss. The UVM is a great tool to study the structure of the angle, similar to histological image. You have the opportunity to do the measure of each structures. And you can see the black arrow. The black arrow shows the most important landmark for the drainage angle measurement scleral spur. The main causes of angle closures: iris, pupillar block, ciliary body, iris plateau, lens, phacomorphic, post-lenticular uveitis, other cysts, tumors, ocular trauma, and others. The UVM allows to identify pupillary block and angle closure. You can see in the picture the convex configuration of the iris. The rod of the iris closes the angle, central iris attached to the lens. Nowadays, ocular hypertension and glaucoma are becoming more common in patients with cataracts, in which the increase in lens volume causes the structures to move anteriorly, generating pupillary block and angle closure. And we can determine it with the measured lens bolt. Is very important in our practice. It's only one line to spur line to spur line, and the anterior caps of the lens to the scleral spur line, and the other line with endothelium line to a spur line. And when you find the anterior lens ball is more than 1/3, your ball lens is positive, and you have a great risk of pupillary block and closed and angular close. Now, I am going to present a series of cases where the UBN allowed to find the origin of increment of intraocular pressure. Case 1. This is a patient, 65 years old, with reduction in visual acuity and increase in intraocular pressure, 30 millimeters. You can see in the picture the presence of nuclear cataract and narrow anterior chamber, and gonioscopy shows angle closure in 360 degrees. And you can see the UBM is perfect because you see showed the facomorphic component with pupillary block and angular closure. But you can see this is my same patient after the cataract surgery. The UBN allowed to see the resolution of angular closure and pupillary block. But the most important was that decrease the intraocular pressures. This is other patient, case 2. 65 years old female patient, antecedent glaucoma surgery, trabeculectomy 2 years ago, and post-op retinal detachment of OD with silicone oil 1 year ago. Presence of silicone oil in anterior chamber and highly increased blood filtering with increase of intraocular pressure 26. The UBN allow diagnosis of presence of silicone oil in anterior chamber, and the most important, an emulsified silicone oil in filtering blood that caused the increase in intraocular pressure. Case 3, 68 years old female patient, post-op cataract 3 years ago, presence of recurrent high edema that forced her to seek for appointment weekly. Decrease of visual acuity and increase of intraocular pressure, 24, presence of edema and presence of high FEMA in anterior chamber. And UBN allow to the identification of the tilt of intraocular lens and the contact of the haptic with the iris and ciliary body that were the cause of recurrent high FEMA. Case 4, 45 years old male patient, antecedents post-op trabeculectomy 2 months ago. Presence of intense ocular pain, great conjunctival chemosis, and decrease of visual acuity, and presence of blebitis, hypopion, and anterior chamber. The UBN allowed the identification of corneal edema and great cellularity in anterior chamber and blebitis associated to a diagnosis of endophthalmitis. It's very important. The UBN is a great tool to examine the trabeculectomy. You can find the reflectivity, the height, the subscleral space, sclerectomy, cyst change. It's a great tool and to help identify the possible cause of failure in a timely manner. Case 5, 51 years old male patient, conjunctival lesion in OD that compromises the scleral corneal limbus in inferior temporal quadrant. Time of disease is very important, 1 year, many times. Anterior chamber activity, decrease of visual acuity, presence of uveal ectropion, and increase of intraocular pressure. Peripheral synechia towards the lesion and corneal edema. And UVN allowed the identification of conjunctival neoplasms with infiltration into the anterior chamber, presence of cellularity and synechia, which caused angular closure on the site of lesion. It is important to follow up the conjunctival lesion with UVM to prevent the future infiltration in other structures. Case 6, 52 years old patient, antecedents, episodes of decrease of visual acuity for about 10 years, cataract in both eyes, intraocular pressure increase in both eyes, 22 and 24, narrow anterior chamber, and the presence of abundant pigment in anterior chamber in both eyes. UVN allow to identify the rare condition consisting of the separation of the anterior iris stroma from the posterior stroma with abundant pigment release into the anterior chamber iridoschesis. This condition produced cataract and angular closure glaucoma. Case 7. 45 years old male patient, antecedent post-ocular trauma in OD, decrease in visual acuity and increase in intraocular pressure, 30 millimeters, transparent cornea, deep anterior chamber, and presence of petreous in anterior chamber, aphakia. And ultrasound would be allowed to identify lens dislocation in vitreous cavity. UVN allow to identify the presence of aphakia and the vitreous in anterior chamber. Case 8, 66 years old female patient, antecedents, post-op glaucoma 1 week ago with AMET glaucoma bulb. Decrease of visual acuity and increase of intraocular pressure, 34. Presence of atalamia, edema, and lens intumescence. The UVN allowed to see the presence of atalamia, anterior synechias, the drainage tube in anterior chamber, and the presence of cataract intumescence that cause angle closure in 360 degrees due to phacomorphic component. This complication could have been avoided if UVN ultrasound had been performed before the surgery, because your plan would have changed and would have had the cataract surgery and the implantation of the drain device at the same time. If you see the phacomorphic or you see the cataract, it's very important that you take decisions, but always before use a UVM for take a decisions in these special cases. Case 9, 45 years old, male patient, visual acuity decrease in OD, 20/15, and decreasing in the left eye, associated to pain in both eyes, intraocular pressure increase in both eyes, median anterior chamber with phakia and angular closure also in both eyes. The UVN allowed to identify the presence of iridociliary cysts that cause the angle closure and the increase of intraocular pressure. Diagnosis of this condition is pseudoplateau. Case 10, 62 years old female patient, pain in both eyes associated to progressive decrease, visual acuity 20/60 in both eyes, and increase of intraocular pressure, median anterior chamber in both eyes, phakia in both eyes, gonioscopy, angle closure in both eyes. The UVN allowed to identify the different characteristics of iris plateau configuration. Anterior chamber central and deep, iris rod angle, iris profile flat, ciliary body anterior, and sulcus collapse. And in my country, it's very frequently to find this condition. It's very important for this reason to do UBM. Case 11, 22 years old female patient, antecedent cosmetic implant surgery in both eyes 3 months ago, and increase of intraocular pressure. And wow, it's terrible because a specular microscope decrease of endothelial cells. This condition is terrible because many young people who want to look more attractive undergo this type of surgery without knowing the consequence of their ability to see. The UBN allowed to identify the cosmetic implant that showed the angle closure in 360 degrees. Case 11, 72 years old male patient, antecedent cataract surgery in OD 2 weeks ago, ocular pain and blurry vision in OD, and decrease of visual acuity and increase the intraocular pressure, and edema, medial anterior chamber, and presence of cellularity. This is important for all the people to control the surgery. UBN allowed to identify the IOL in sulcus and the uptick of the lens in contact with the iris rod, resulting in angle closure. Case 13. 72 years old male patient, antecedent post-op of retina in OD with silicone oil 8 months ago. Reduction of visual acuity and intense ocular pain. The intraocular pressure 45. In the picture, you can see the presence of iris bombée, posterior synechias, and conjunctival chemosis. The UBN allowed to identify iris bombée, pupillary block, angle closure in 360 degrees, and the presence of silicone oil behind the cataract. Case 14, 66 years old, male patient, antecedent post-op cataract surgery, 1 week ago, reduction of visual acuity, and a great pain and intraocular pressure in 32. Oh, this is terrible. This is the last, and I want to, well, for me was a great surprise. The complication has been avoided if UBN ultrasound had been performed before the surgery, and you could have identified the great tumor in ciliary body and multiple cysts. And the BMODE confirmed a melanoma in ciliary body. The UBM is a great tool for see the IOLs. This is other terrible. And it's a great surprise for me. The UBN allowed to identify and see with Dr. Mario de la Torre. Do you remember, doctor? Yeah, the doctor said, wow, what happened? ICL inverted. And I see 4 inverted in 1 year. It's terrible. Please take care. And you see the decrease of endothelial cells is terrible. And it's a young people. And other tools of UBN is the ocular trauma. The UBN allowed to identify the anterior capsular rupture. This is courtesy of Dr. Mario de la Torre. And UBN allowed to identify the lens luxation in the anterior chamber and posterior capsule rupture. In uveitis is a great tool, cataract and iridocyclitis and choroidal effusion. It's very important that you use this tool that is very, very good before your surgeries. Congenital glaucoma, Peters anomaly, corneal leukoma, iridocorneal synechia is a great tool, UVM, for the children's. Congenital glaucoma, axenfeld rigor, posterior brotoxon, stromal hypoplasia, uveal ectropion, corneal opacity, microcornea, choriotopy. And conclusion, it is the only device that can evaluate the eyes with opaque corneas. This is essential in the evaluation of the angle configuration and the mechanisms of closure in a primary angle closure suspect or glaucoma case. It is also vital in the plateau iris configuration and retroiridal process. UVM is considered one of the best technologies that visualize the ciliary body because the UVM see behind the pigment, remember. Also, it is used widely in the preoperative evaluation as it can help the surgeon develop the optimal surgical plan. Tumors of the anterior segment can be evaluated using UVM, including iris and ciliary body melanomas under anatomical position and contact. Corneal pathology such as scar dystrophy or degeneration can also benefit from UVM without impacting corneal biomechanisms. Finally, UVM can be used in children. Thank you so much. I am very happy to be part of a great group of ultrasound diagnosis. In my country and in my world. Thank you, Cartagena.
Thank you, Gabriela, for this nice presentation of several cases. The most important thing, as Gabriela mentioned, is that UVM as a technique is very useful in all the definition of the risk of angle closure and another pathology related with glaucoma. And we realize that the gold standard is still gonioscopy because there are things that you can't see with UVM, but you can see with gonioscopy. Pigmentation, you can see also blood, and in many parts also the dysgenesias. But this is another way to have more information. The issue is we realize that we must combine everything that we have in our hands. And the limitation of gonioscopy is it stops in the pigment epithelium of the iris. And now we have the possibility to go deeper and understand things that were not understood in the past. When I review the glaucoma books, for example, I see the classification as a SPET, or I see also the other classifications. And in the past, they have no UVM, but they recognize the different position of the iris, also the insertion. Right now, we have the capability to look all things. And we are committed to show these images in the best quality. All the images you already saw is our contribution to, if you have a good image, you have a good diagnosis as well. Okay, the next tema, yes, will be standardized echography. Okay? No. Okay. I make the explanation of it. I hope I will work it properly. Okay. This is our symposium. Why do we need ophthalmic ultrasound? In the past, people say, okay, forget about ultrasound, OCT is the king. But right now, look, we are many people here. Listen about ultrasound. we are still interested in ultrasound. OCT is an exceptional tool. Huh? But I always say something is beauty and something is handsome. In Spanish, it's different to say bonito than guapo. Bonito is something that is relative, but guapo is much, much better. No, I'm not guapo at all. But the difference is, guapo is for everything. Opaque media, infections, then cornea, opacity. Bonito works only in the better conditions. Guapo, it works, it's a full terrain, four-wheel drive. It is for the ultrasound is this. It's el guapo. Remember that always. Okay? We will talk about standardized echography in tumors. Okay, standardized echography is another way to perform ultrasound. You can do or you can't do it. It's your choice. It's not bad, it's not good, it is different. We can use it. I realize there are people that can make the diagnostics only with BMODE. I really appreciate that because I can't. I need something else. I'm not so, how do you say in Mexico, I have no colmillo. But there are people who can do that. But there are some people like me that can do that, and I use standardized ultrasound to help the way to use the diagnostics. Is necessary everyone should use it? No. No, I tell you the truth. If Carl heard me, will kill me. I do my diagnosis almost 70% using only BMODE. But when I have a doubt, I go to standardized ultrasound. And that is the big difference. I am not dogmatic. I try to say everything you can use is good. And I show you, for the young people, this alternative to develop that we learned. My mentor is Gerhard Hasenfratz. I consider him my father in ultrasound. My grandpa is Carl, very grumpy also, that's the word. But I am very proud to show both of them because they deserve an homage because they developed in the earliest 60, and the main purpose is something different. It's to make tissue differentiation in ocular, orbit, and anexa as well. And I learned that Doppler is also important. It was part for the very beginning for standardized echography. Okay, at that time, you remember also Gilberto, it was a acusome, something that's used in gynecology just to hear if there is a train sound inside the, yes. And I learned unidirectional Doppler with the Kranz-Müller machine. And this is the people say, okay, you're talking about Doppler, is this standardized? Yes, it's also considered standardized. We must be open for it. Okay, what's this standardized echography? What is standardization? It's one echographic language. We consider with reliable, understandable, comparable, and repeatable optimal results. But you need to be trained on it. You must spend time learning to recognize things. BMODE is easy because it's very friendly to see. You need to read the spikes. You must read all the many concepts. It makes it a little bit difficult. It's okay. And right now, the only devices with a standardized scan by Osonic, because the last time, okay, I have a standardized device. Okay, who standardized it? Can be Pancho Villa, Perez, whatever. But the standardization by Osonic, the only ones that are recognized are Absolute and Aviso. It is possible to get another standardized, perhaps? Yes, you can make your own standard. In the very beginning, it was the standard for Bushman and also the standard for Osonic. But we are talking about the standardization by Carlos Sonic. Okay. In my hands, I don't talk about everyone, I mean, my hands, using BMODE alone for me are difficult to differentiate. For me, A mode shows the internal structure, I mean the standardized ultrasound. But you need, sorry for the Spanish there, you need a special equipment to study that. You use a mode A, standardized, contact B mode, and bidirectional Doppler as well. You must have a standardized equipment, an examination also standard, a special amplifier at the amplification S-curve. Okay, what is the difference? Why you can't do standardized with the biometry pulses? Both are A mode. Yes, but standardized has a parallel beam and biometry has a focus beam. I mean, if I here with my scan, I have in focus this line, nothing at the sides, but from the very beginning to the very end, until the place where the echo stops as well. When I have focus beam, I mean I have a focus in an area, 23 millimeters, and then you have a panus area. After this and before it, you are the focus. They're good. You can combine both. Okay. This is not standardized echography. This is vector C. You can use it? Yes, you can use it. But the information that you get depends about the gain that you use. You don't know what is the exact gain for the tissues. You can use as a reference, you can, but it's different to standardized. Because standardized is a devoted Prof to make the tissue differentiation. How we can do tissue differentiation? Do you know what it is? Do you know the language? Huh? Yes. Do you know what it means? No, but do you know the language? If you know the language, you say like Roberto say, stop. I saw it in Morocco, and it says, okay, you see that? You see both. A mode, that is the writing, and B mode is the shape. And you must combine it. And you have the idea that you can use both to make a comprehensive diagnosis or something. Okay? What is tissue differentiation? That is, okay, let's do it easy as possible. There's the interpretation of the images that sound produce when it passes through a tissue. What is that? I was talking to you, Mario. Are you crazy or what? Had you drink yesterday many mojitos or what? Okay. It is correlated with internal structure and is diagnostic by means for pre-established parameter. Okay, I ask to you, all of you, close your eyes. And I will do something. Sounds different. Why? Because the internal structure is different. Something is a plasma, plasma TV. This is wood. This is metal. This is wood, but have air inside. And the sound is different. Then you can see in your voice, when you speak, there are also spikes. And if I record every one and can recognize the way that you have to speak, how are your spikes, I can recognize you. This is the voice recognition police and Secret Service use sometimes, but we use in a better way, we use in ultrasound. Then, with ventricular tumors, they speak different, they sing different. They have a different way to react when the ultrasound passes through. And it all depends on the internal structure. And if you know histology, you know that every single tissue are different in the histology. Okay, there are people that can't do that for sure, but I'm not Messi. I am Cuevita. This is the forward of the Peruvian selection that failed the penalties, but Messi do that. Yeah? And right now, there is one metastasis, there is one hemangioma, and there is one melanoma. If you are expert, you can do that. It's so easy. But if you're not expert and you want to help, you use standardized. And you can see that the melanoma is low reflective, hemangioma is high reflective, and the metastasis has the V shape. What is the difference? You have a help, you have an extra aid to do your diagnostic. No more than that. Huh? And that is also in the orbital tumors. Here is worse, because in the orbital tumor it's most difficult. Okay, and you can see, for example, this one, and in the other side, they looks very similar, this one and this. Okay, you must also correlate with the situation, with the form, where it is, etc., etc. But if I show you a picture, it's almost impossible to say which one is one. But look, this was a lymphoma, no problem, but it's very, very difficult and very, very dangerous. But you have a lymphangioma with the same shape in BMODE. You have an hemangioma, and you have a carcinoma, and they look similar. And, okay, it's easy to see the cyst, it's easy to see the other one. What I'm trying to tell you is a help to make your diagnosis better. And the internal structure defines the reflectivity. The compact tumor cells, they're partly homogeneous, without large interfaces, low or medium internal reflectivity. A large tumor presents areas of necrosis of complex vascular system, more interfaces, greater attenuation. Okay, the question is, and the problem is, you must learn to do that and to translate the image that you are seeing in your brain to recognize the pattern. Artificial intelligence will help us in the future, I realize, yes. And we need to, also, this is a very controversial case, but we need it. We need to do it easy. Look, the difference here. Hemangioma, carcinoma, and melanoma, they have different structure, they have different images as well. Different spikes. In this case, B-scan suggests malignant melanoma in both sides. This is a very old picture, it's 2000. And still it works. Low reflective melanoma, high reflective hemangioma in the BMODE is similar. It's the same feature. You are walking in Sao Paulo or in Rio de Janeiro. You see a mulata, fantastic, curved lines, and you, oh, how beautiful are you? And he answered, gracias. This happens also in medicine. Excuse me, open your eyes. Excuse me, madam. No, excuse me, sir. No, madam. Oh, excuse me, madam, you have a prostatic cancer. Okay, there are many things that can confuse us, but we must look the images to be sure what's behind. Okay, the nevus, it's very important to differentiate nevus from malignant melanoma. They can change. Nevus is high reflective, melanoma is low reflective as well. You can have similar images. Then you can have similar images in BMODE, and BMODE provides form, topography, localization, size. It's perfect, it's good. But you have an add with the A-mode concerning the reflectivity, the structure, etc. Consistency, and also surface. And you can differentiate them very easy. Also, in retinoblastoma, you can use B and A scan. You see some calcification. Please, any calcification inside the eye for a little child, is retinoblastoma until you demonstrate that it's not. Yeah? You can see also, look what different is the behavior in BMODE. Inside the eye is white. Inside the orbita is black. It's the same tumor, but with different media. And in A standardized, you can see this, they are the same. Yes, low reflective, medium reflective as well. It makes a little bit different. Andrea Arango is here? Raise your hand. Yes, this is your case. I take it for you. I recognize you as I look this very nice picture about melanoma with external esophageal melanoma as well. Melanocytoma is high reflective, looks like, but it's not a garota. And choroidal hemangioma, sorry, I go back. Okay, you see the choroidal hemangioma with the high reflective, the metastatic carcinoma with the nodules with BMODE, and also the M shape or V shape as a metastasis. Choroidal high reflective, very brilliant. You can correlate both if you have a doubt. Age-related macular degeneration, macular pseudotumor, Kuhn-Junius disease in Europe, and you can see the different interfaces with different reflections inside of the tumor. And malignant melanoma is for large, one of the most important things. This was the first one that we took with the Absolute in Chile, in SIDUO in Chile, and this was a patient with malignant melanoma. Okay, right now BMODE is fantastic. You can see here inside vascularizations. In the past, we couldn't say that. We couldn't saw that. But you can see also vascularization here in these spikes that get very low because this is fluid inside. Okay, what is the standardized definition of the melanoma? The anterior limit is defined as prominent, constant, high reflective initial spike. That means it's a solid lesion. Regular, homogeneous, because the internal structure, the architecture, is low reflective aqueous. And look, this is in real time, middle low to low reflectivity as well, because it all depends how you are achieving the tumor. And behind the limit, I mean bigger ones, the initial spike is followed by multiple homogeneous regular echoes of medium to low or low reflective. But, as many of us knows, and Eduardo is here, everyone is here, can tell us, and we make a study for the Latin American, Hispano-American, Latinos patients, but I don't know why, because our pigmentation, we have different reflectivity. When I came back from Germany to Lima, I have a problem, because I was learning standardized echography in European eyes, and then I came back, I saw Cholo eyes, and those were totally different, because the rays, because our characteristic. And then we saw that reflectivity tends to be greater in amplitude than in Caucasian patients. You can see the vascularization, these echoes. We are using zoom as well, some cases, to look at. And in large melanoma, please look and make a sentence about the first 20 microseconds of the tumor, because there is changes in the physics of the sound, the ultrasound, deeper. And then B-scan does give exact measures because there's the blooming phenomenon. It all depends the gain that you use, because it's bright. And when it's very bright, it has glare. You must decrease the brightness or the gain of your machine. With A-mode, you don't have that problem, you can see. But you need B-mode to make the longitudinal, and you need the transversal diameters for the tumor in order to make the brachytherapy. If you don't have no information, that's the only way you can get it with B-mode, then you go and the maximum height, we always do it with A-mode because we can clearly say the boundaries of the lesion. Again, we use transversal, longitudinal, and the maximum height. And look this is another, hey, this is Mr. Cisticerco. It's a showman. Please make Hello, say hello to the audience. Hello, wake up. Wake up. No, you are sleeping. Okay, thank you. You can see with the resolution of the 20 megahertz, even the movement of the scolex and also the membrane. And you can see this is a cystic circus as well. In orbital tumors, 95% of the lesion can be detected, 85% can differentiate. Sorry, that is my experience. There are speakers that say that they do more. I can't. This is my experience. I want to be true. And then, everyone has his own feature as well. Metastatic carcinoma, lymphoma, hemangioma, and look, preseptal orbital abscess. This is in the book with Olivier. We describe that kind of lesions in your book. Also, subperiosteal access. Also, pseudotumor as well is common, low reflective, homogeneous structure, moderate sonic absorption, and we can have a feature, and we can see it in real time as well. The yellow arrows show in this case the choroid, the sclera at the tenon in the posterior scleritis as well. And you have an idea what's going on in that kind of problems of the orbit. Again, you have the posterior scleritis, tenonitis, choroiditis, and because ultrasounds go deeper, you can see the myositis that always is involved in the process. You can see also myositis, and you can make differentiation in the insertion of the muscle that is thicker than normal, and you can measure that with the A-mode with low reflection in this case. Okay. Oh, capillary hemangioma seems to be a regular structure, high medium reflective, interspecs with low reflective, and you can, in a gross limit, but you can depress the lesion as well, very soft, compressible. And this is important to use the probe not only for the representation, but also to feel. It's like your finger. When you do a normal examination in general medicine, you use your finger. In orbita, it's essential. Known or mild vascularization. Lymphangioma as well. You can see the septum and also inside the lympha. And when you look at bleeding orbital lymphangioma, the reflection decrease because it's blood inside. And orbital varicose veins also are able to see low reflective because it's blood inside. And arteriovenous fistula as well, you see low reflective, and you can see the ophthalmic superior vein as well. And sometimes the thickness of the optic nerve. And look, you can see something that passed through the orbita with something inside that is moving. And you can see, and you can compress it. And it is compressible, it is low flux. It is not, it's high flux. But sometimes you can't see it with tomography or even MRI sometimes. With ultrasound, it's possible to see that. And lymphoma as well, low reflective as well. And sinus carcinoma is difficult because sometimes you see indirect signs for it. Metastasis as well, they are very difficult to differentiate. Metastasis eye to orbit, you can see that. Rhabdomyosarcoma, usually extraconal. Gabriela, thank you very much. They are your pictures. I like, you know, if someone use your images, it's because they are good. Yeah? And that is the reason when I use one image for someone, I say that image belongs to. And I use it because I like it. You did your work good. And knowledge is to share. It's a treasure that you must share. Okay? And this is supranasal localization in the embryonic SRM. And also you have well-defined sometimes in early stage, the rhabdomyosarcoma, well-defined borders. In the later stage, irregular borders due to pseudocapsular invasion. internal structure from medium to low to very low reflective. In some pseudocystic tumors, embryonic SRM, spindle cell type cells with abundant cytoplasm and separated by edematous fluid. And this is the reason we have a very low reflection inside of, okay, congenital orbital cyst, dermoid cysts as well. They are different, they look different, they have different shapes. I don't stop in every single thing because it's a matter to take a long time. Dermolipoma as well, corystoma, that is my brother, the photo of the eye of my brother, and dermolipoma canthal sternoseptal. Mucocellae, also you can have homogeneous regular internal structure, very low serous, but low if there is pyocellular reflectivity, and internal signals of mucocellae, weak kappa angle, that means weak zone of absorption, and depending on the bulbous sinus, a large rounded structure. Okay, I just in the very final part, mucocellae as well, you can, don't forget, ultrasound is not a diagnostic method. It's a help to the diagnostic. Please, it's an auxiliary method to help you to make the decision of the diagnostic. Remember that. Mucocellae is smooth and very well differentiate boundaries. You examine total size of the lesion, intraorbital and intrasinusal portion. Gerhard has in front of me, look, the zigzag. I didn't understand in the very beginning, but when I saw the bone, just inside, and you see one or two images, I understood what is zigzag as well. Yeah? Generally, the largest portion is out of the orbit. Always contralateral comparison as well. And mucopyocellae, look, the structure is quite different and low reflective in this case. And dacryocellae as well. And you can also see the communication with the lacrimal sac when it is dilated. And this is a cysticercus in the muscle. Huh? But this is extremely rare. Two, one inside, one outside. It's very, very unusual, but we got it once a time, long time ago. And someone asked me, oh, the tumors in the ciliary body, the melanomas are similar to those. Okay, prognostic could be different. Way of the evolution, the evolution is different, but you can differentiate using also the standardized mode to see low reflection of that. Okay, final message. It's an extra tool for you. It can help you to enhance the capabilities of your diagnostic. You can do diagnostic without? Yes, you can. But you enhance your capabilities if you are not Messi. If you are a normal, you are not Mbappé, you are not Cristiano Ronaldo. You are a simple player, you can enhance it with a standardized. And that is my recommendation. Thank you so much. It's your turn, Gilberto.
Okay, I will talk about a B-scan. I was trained by Carlos Soini using mainly the A-scan, but now the B-scan is gorgeous. Okay, this standardized echography was by definition, with these principles, with the A-scan, with a H-shaped magnification, with 8 megahertz, that this is the correct 8 megahertz is perfect to see the eye and to see the orbit, as you saw all the presentation of the Mario de la Torre. And at that time, when I learned the B-scan, there was the name of real-time B-scan. This was the definition, because they were using a very, very old tools with a very on a specific kind of B scan that was difficult to handle. And of course, he was a wise man, thinking about Doppler. And when I was started using the Doppler, was just a very primitive one with making just noise, and he was extremely happy when he found a lesion, vascularized lesion, and he was moving his eyes because he was extremely happy because he was listening the noise through the Doppler. Very primitive one, but now we have a lot of information with new Dopplers, and I think the next talk will be a Doppler. It's a very useful tool that we have to use. Okay. Of course, as an ophthalmologist, we have too many toys, mainly all the optic toys to see the eye. But it's very common in our countries to have opaque media like we have here. And of course, we are, as old friend said, we are in the hands of the echographer, because the one who knows everything inside the eye is the one who has the ultrasound. I started using the very old machines with a B scan, very primitive, and the A scan was just a perfect one with all the information. Now we are using new toys to see the interior of the opaque media, like we will see now. And now I'm using 20 megahertz. I've been using before the 10 megahertz, which is an excellent tool. 15 megahertz, great, but this one is just gorgeous. It's great to have this toy. In this, we can see the posterior capsule very clear. I'm doing this through the lids, and the patient is just looking for the posterior capsule, which is very clear. We don't push a lot when do the echography. And of course, the vitreous is completely clear. And look at the definition with the B scan. We can see the retina very clear. And if in case we are suspecting something, of course, we can use a different tool like the A scan. Of course, I'm more familiar with the A scan, but now these toys. Okay. This is another B scan with 20 megahertz. Look at the imaging. We have the posterior capsule. It's very clear. The vitreous is attached, and also we can see it very clear too. Let's start with a very normal findings in our everyday work. Here we have I forgot the name even in Spanish. The vice ring with this toy is very easy to see the ring here. Of course, there is nothing really new. We can see it also with the 10 megahertz. But with this one, it's very clear to see it. And of course, the information we can give to the physician that's sending the patient is most useful. Also, with the B scan, with 20 megahertz, we see all these opacities. We have a problem with the 20 megahertz. If the eye is full with silicon oil, it's impossible to see with the finest way to see the retina and everything because of the silicone oil. This is a gift to Ramiro, one of the images you can collect here. There is a Diplococcus imagine within asteroid hyalosis. It's a very clear asteroid hyalosis with a Diplococcus for Ramiro. And also, of course, you may see this is the cortex of the vitreous, always is clear. The opacities we have here. This is a beautiful one, and I like it very much. Of course, we can see the disc and the excavation is quite clear using the 20 megahertz. And you can see the excavation is a very normal one, with the rest of the examination is quite normal. This is a patient of mine. She had multiple injections for age-related macular degeneration. And all these opacities you see here were quite common when you see this one. And you can make sure that the patient has several injections before the examination was done. This is another case. Look at this patient had a vitrectomy 3 months before the exam was done here. We don't see the rest of the vitreous, but we see a lot of opacities. It was bleeding again. It's a diabetic, a long-term diabetic, with a very clear, the retina is attached. The excavation is a little bit wide, but we cannot make the diagnosis of glaucoma, as Mario said. We see the imagine, but we don't see, we are not sure that how the pressure is, but the information for the clinician is very good. This is a case with a dry age-related macular degeneration, very small, very thin. It's in case you have the doubt, of course, if it's a long, a big humid retinal degeneration and macular degeneration will be a tough case if you don't see it. This case was sent for an intraocular lens calculation, and when I saw the macula, the first thought was I found a macular hole. With this imagine, I was sure this is a macular hole, and I asked the patient to have a OCT. You can see here the OCT shows the traction and the vitreoretinal traction at the macula, making this terrible thing with changing all the anatomy in the macular area. I'll go back. I was thinking about just a macular hole, but it was really a traction of from the vitreous. But I wasn't able to see the vitreous here in this picture. Nevertheless, we asked the patient for the study. It was most helpful. Of course, we can see the epiretinal membrane here in this case. There's no doubt about the imaging we have here. Very nice epiretinal membrane. Of course, we can use also the OCT to confirm the diagnosis. With the B scan, we can scan everything, all the opacities, except with the silicone, and also having a beautiful images with the B. Of course, we have a vitreous hemorrhage here, and the hyaloid and subhyaloid opacities, and look at the thickening of the retina choroidal layer, which is attached, but it's very, very, very thick. The most common patient we see in my practice is diabetics with the diabetic retinopathy, and of course all the terrible things that happens to the diabetics. And with the B scan, with the 20 megahertz B scan, it's very easy to follow. We don't make the diagnosis until we are sure that having a good B scan. Another case with a vitreous opacities, subhyaloid hemorrhage, and tractions with the B scan, easy to see the insertion of the hyaloid at the optic nerve. Most opacities at the vitreous. And in this patient, there were some areas very clear because of the posterior hyaloid was not open, and maintaining good stand in the vitreous. Here we have this pseudomembrane. We can see it very clear, and moving the patient, looking for a posterior hyphema, but of course with the B scan it's very easy to follow. This patient had a cataract surgery before, 1 month before, and she didn't have the ultrasound. And the physician sent the patient to me because she was seeing very bad after the cataract surgery, and I found a subretinal and subhyaloid hemorrhage. This is a case we don't want to see. It's a lawyer. He had a surgery a week before, and with a blurred vision after 1 week, and the doctor sent the patient to me and said he's upset, the eyes red, and I start with the B scan. And you see all the opacities in the B scan, a lot of noise, using the 20 megahertz, a lot of noise here. But I have the A scan. Of course, before I made the diagnosis, I went to my A scan and look at this the vitreous is completely normal. So my report was just inflammation. It's not an endophthalmitis, but with B scan, just pure B scan, I was scared when I saw the imaging. The excavation now with these toys are very easy to see. When we have a new instrument, we start seeing more excavation than the real ones, because all the resolution of the instrument makes us to make the more mistakes, reporting more excavation, wide excavation instead of the normal ones. Of course, when we have this excavation, it is very, very wide excavation. You look at the vitreous, it's very clear here, the vitreous with the B scan, and almost detached, but the excavation you can see in a very clear way. This is an old case. I've been presenting this case with the. ¿Puedes correr el video, por favor? A ver. It was Dr. Takane. this case, and look at the cysticerco. This is an old machine with a 10 megahertz. The patient was with a cataract, and he was sent to the echo department to calculate the intraocular lens. We found the cysticercus with a total retinal detachment. This is the date. This was 2005, 2006, and now I have a courtesy of Mario de la Torre with the cysticercus you saw. This is with the 20 megahertz. Even the instrument was quite old. The difference between the previous one and this one with the 20 megahertz, it's more clear to see this one. This is Mario de la Torre's case. Also, was a patient sent to me just to make the IOL calculation, and I found some vitreous opacities, which I will say was quite normal, and the superior part of the eye, I found this retinal detachment with a cyst inside of it. It means chronicity. We saw some cases that were presented with a cyst. It's a small cyst we can detect here with the instrument. Look at the cyst inside of it. It's a very small one, and the detachment is in the optical axis of the eye. So the surgery will be performed without problem. And this is a case with a retinal detachment with the operculum here on the upper part, the operculum, and there is here the tear of the retina. All the retinal detachment. It was with a 15 megahertz probe, which is excellent. But look at the imaging with the 20 megahertz. Look at this as a 20 megahertz with a new toy we have at the clinic, and look at the cyst within the retina. Look at a small cyst. We can see a small cyst in the retina. It means to report to the physician that it was referred the patient to me. It was a retinal detachment with some kind of chronicity, just for the results after the surgery. Even the retina is attached. The results are quite poor. Of course, we can follow the patient after surgery with a buckle. Yes, the 20 megahertz probe with a buckle. It's very, very well positioned. The buckle, no, is not too high, the position of it. But in some other cases, we see a little bit higher. The buckle is too tight. This patient still has the vitreous. You see the posterior part of the vitreous. Looking for how big, how tight is the buckle after the retinal surgery. Well, of course, to differentiate the tumors, A scan is the one is the king to follow. But with the B scan, I understand many people don't have a scan, but with the B scan you may have the idea. Of course, the first thing you have to think is about the clinical history of the patient. And of course, this is a lady with a breast cancer, and she was sent to me because she lost a lot of the vision in her right eye. And see, the tumor is very well defined, and of course we see the retinal detachment. The vitreous is here present, and I don't see if the tumor I don't see lesion behind the sclera. It's quite clear, the imaging we have here. And also we can make the measurements just to follow the patient. Of course, the prognosis is not quite good because it's, of course, a metastatic lesion. And this is one of the slides that belong to Mario de la Torre. He gave it to me. It's a very clear lesion. It's a very well-defined lesion with a adjacent retinal detachment. Of course, the A scan is the answer. A scan is the answer to when we have a tumor. Of course, the A scan will be the best way to make the diagnosis. Of course, we have another case with the reflectivity is different, and of course, with the A scan, we can make the diagnosis, even that the B scan is gorgeous, and when we see this B scan, it's much easier to explain to the patient and explain to the rest of the physician, because many of them, when they see the A scan, they see like electrocardiogram. They don't understand nothing at all. But with the B scan, much easier to explain. We have a tumor, very well-defined tumor here. Look at the lesion. You have the retinal detachment, but the answer again with the A scan, just moving is not well organized as a metastatic lesion, of course. Seeing the B scan is just a dome-shaped lesion. And the A scan, of course, is the answer. Even when we have a very nice toy, like a 20 megahertz, still we need the A scan to make the diagnosis. This is a young lady. She was referred to me. She is 12 years old, and she didn't notice anything. And at the school, the teacher was trying to make an examination, and with her right eye, she saw nothing. And she was sent to a doctor. At the end, finally, she went to me, to my office, and she is 12 years old with this lesion at the macular area. You see here the optic nerve, and this is the macular area. As a Hispanic girl, 12 years old, with this lesion. Say, okay, it's very unusual because in our races we don't see very common this kind of lesion, and the age is not common either. I made the A scan. I was not sure about the diagnosis. Is this a real melanoma or not? I mean, the A scan I wasn't sure when I saw this A scan. It was not that clear. Mario said that when he came from Berlin, from Germany to Lima, he found a different pattern of the A scan lesions, and here, this is if somebody asks me, say, I doubt this if it's melanoma or not. Okay, the eye was enucleated because of the clinical manifestation was real melanoma, and at the end the result was melanoma and without metastasis. And of course, the other tumor we are leading with is the retinoblastoma. This is a 15 megahertz probe. Is of course useful. The 10 megahertz probe is extremely useful. But the 20 megahertz is more clear. We see all the calcium inside of the tumor. Of course, as a complement, always using the A-scan to have the correct diagnosis and make sure that the patient will be handled in the right way. This is the last picture, is a patient with a trauma. You see the inflammation of the muscle here. We have here, including some layers here. And the optic nerve was very close to the optic nerve. And here we have some opacities at the vitreous. Okay, this is when Edward I was crowned in Scotland, and we were using the kilts, and well, several people. And now this is the new group of the SIDUO committee in Paris. We were having this wonderful time now talking between one and the other, and it's very nice to have friends like these ones. And this is me when in an invitation of Eduardo Moragrega in the ice bar. I was attending the rest of the drunk people. I was not drunk at that time. Thank you so much.
Thank you. Thank you very much. The take-home message is we are committed with all of you to work together. We are a company. Right now I talk like a scientific director of Cantel, not as president of the SIDUO, that we have the commitment to give you the best image you can get with the devices. On the other hand, I also, as president of the SIDUO, see nothing is perfect. Everything can be do better. Take the message home. Try to do your best, try to enhance your capabilities. You have the opportunity with everything. And we want to show you the advantage of our UVM, our 20 megahertz, and the advantage also for standardized. The choice is yours.